Okay, hey guys, Julie here, Sunday night, and I wanted to tell all those mothers or individuals that do play mother roles out there a official happy Mother's Day. I hope you guys had a wonderful day and really enjoyed doing things that you love, whether it was spending some time with your family, taking some you time, or just doing those everyday things that you like to do. Going for a walk, watching movies, baking, cooking, that sort of thing. So happy Mother's Day. I wanted to welcome you guys to our Sunday night workshop. We're going to be talking about pelvic health. Now, pelvic health is a very large umbrella, and it's a hard kind of topic to condense. My goal tonight is to educate you guys on the types of conditions that you can have with respect to pelvic health, and what factors can influence your pelvic health. And it can be relevant to individuals who haven't had kids. It can be relevant to postpartum moms, or even if you're not postpartum and it's been years that you've had kids, you may still suffer from some of these issues. Men as well suffer from pelvic health concerns. Some of them have had surgery, prostate surgeries and whatnot, and some have not. Kids also suffer from pelvic health issues. You commonly see like the kids who suffer from incontinence and bedwetting, and that sort of thing. So this is going to be a very broad topic. And if you guys have any questions, feel free to ask during the workshop, or you can reach out to me after, and I can hopefully shed some light on whatever's going on. So, pelvic health, what is it? In the clinic, we see a variety of different patients, and it's ranging from, the most common, I would say, which happens in about 1 in 4 women, is the complaint of leakage, or it's also called a stress incontinence, with things like coughing, sneezing, jumping jacks, running, that sort of thing. We see individuals who complain of like a pressure feeling down in their vaginal area, and that sometimes can be linked to things similar to a prolapse, so an organ prolapse. And people say, well, what's an organ prolapse? It's I can't always say that it's postpartum. We do see it in a lot of individuals who do like high level training, simple things like CrossFit, weightlifting, that sort of thing. Your bladder, your rectum, your uterus, it's all your organs kind of that are above your pelvic floor. And we can get a descending component to those. So that's what a prolapse is. We see individuals who have pain with intercourse or any kind of intimacy. So that's a pelvic floor issue as well. And then we see like your simple things like incontinence, which I mentioned earlier, and constipation and things like that. So surprisingly, physio is a specialized area with respect to pelvic health. So you can see a therapist who kind of understands how the pelvic floor works, and hopefully be able to help you. Now, and then I also mentioned men. We can see men with pelvic health issues, whether it's urge incontinence. They may have some numbness, nerve sort of issues in that area, as well as it's really common to see men post prostatectomy. They tend to have a little bit of issues as well. So where do I start? Like I said, it's such a broad topic. So I guess I could start with like, what is pelvic health physio? Everybody think of pelvic health physio as like Kegels, you contract your pelvic floor, and that's it. But what we see clinically is when we ask individuals to do a Kegel, half of them do it wrong. So instead of actually performing a Kegel, they're actually like bearing down as if they're having a bowel movement instead of actually lifting up. So that's a really common issue. And people say, well, will doing Kegels solve my problems? And unsurprisingly, the answer is no. As physiotherapists, we assess you as a whole. So we look at your lumbar spine range of motion, your hip range of motion, pelvic movement, and then we take a look at the pelvic floor as well, depending on what your complaint is. And people say, well, how do you look at your pelvic floor? We do an external exam. And then if we deem that it's appropriate and the patient is comfortable enough, we do an internal exam. So similar to what your OB would do, your family physician, if you're having a checkup sort of thing. And what we're basically looking for is certain things. So tenderness, soreness, tightness in the pelvic floor muscles, weakness in the pelvic floor muscles. Now, when we do that, we typically try and explain to patients what their pelvic floor is. Because if you don't quite understand what your pelvic floor is and how it works, it's really hard to understand why you're having the symptoms that you're having. Does anybody know kind of what your pelvic floor is? Anybody know what it looks like, or the shape, or the function that it is? So your pelvic floor is basically the muscles that occupy within your pelvis, and they are basically like a sling. So if you think from one side of your pelvis to the other side of your pelvis, they act like a sling. So you've got your organs, like your bladder, your uterus, your rectum, everything above the sling. And they basically are supposed to support, yes, kind of like a trampoline. So someone just made a comment that it's like a trampoline. It's like a sling and a trampoline. So it's supposed to spring up and down to support our organs when we do activity. And now a lot of people don't realize that the coordination of the pelvic floor is huge alongside the diaphragm. And if you guys had watched my previous workshop on breathing and breathing patterns, you'll see that the two are linked with respect to kind of a piston effect. So I'll explain that in a second and how it works. But a lot of patients that we see, let's start with like a stress incontinence, people who are leaking with coughing and sneezing. People say, well, why do I leak with coughing and sneezing? When we cough and when we sneeze, there's an increase in intra-abdominal pressure. So you get that explosion of pressure in your abdominal region. And the pressure has to go somewhere, right? Has to go somewhere. It's going to go out through your belly. It's going to go out through your back. Some people, blow their back out with a cough or a sneeze. But it can also affect the pelvic floor. So I have a pelvic floor model here. I'll show you. So this is basically your pelvic floor. So you remember how I was saying that it was kind of like a sling? So this is your pelvic floor. This is your tailbone. And you can see that there's a variety of different muscles that support the pelvic floor. This stuff doesn't faze me when I talk about it anymore. So you guys will find this really interesting. This is your vaginal hole. This is your rectal hole. And you can actually see that there's a variety of different muscles that actually sling around the vaginal hole and then around the rectal hole. And then there's ones that go from the pelvis to what we call your tailbone. It's also called your sacrum and your coccyx. And they are basically that sling or that trampoline that we were talking about. So if you contract a muscle, it's supposed to tighten. A lot of people that we see in the clinic have a weakness in their pelvic floor. When you have a weakness, you can't fully contract the muscle, right? Or if you have increased tone and the muscle's really tight, it's hard to get that last little bit of tightness because of the trigger points and the fascia being so tight. So if you can't fully close the muscles surrounding the vaginal and the urethral hole, it's really easy that once you kind of cough or sneeze or jump and you have that downward pressure, that it's going to push on your bladder and you're going to get a little bit of leakage through the urethra. So that's typically why, is that increased pressure that the pelvic floor can't fully close that canal, and that's when we start to get leakage. And a lot of women think that that's normal and that it's okay postpartum, but I'm telling you that it's not, and it is treatable, and it's something that's usually very easily treatable. And then, like we said, the same thing happens with people who have hypertonic or tight pelvic floor muscles, that they're already tight, but they can't get that full contraction when they need to, when they cough and when they sneeze. So that's what we typically see quite commonly in the clinic, and that's what we're treating. Now, where to go from here? So postpartum in Europe, you guys probably be surprised to know that pelvic health is the first line of treatment for individuals postpartum. So every single woman who has a child in Europe is usually referred to a physiotherapist to address their pelvic health, whether or not they're healthy or they're having issues, to ensure that they are on the road to recovery and that they are less likely to have pelvic health issues down the road as well. And when I say that, it's because, you know, if you have a weakness in your pelvic floor, you can have continued issues with like a stress incontinence, or a lot of women and men have a urge incontinence, when you just kind of have that feeling that you always have to go, and if you don't go, you're not going to make it to the bathroom. So an urge incontinence is really common as well. And there's a lot of different factors that contribute to an urge incontinence. And that can be, you know, habits and things like that. So that's what we've got: the stress incontinence, we've got the urge incontinence. We talked about the tightness in the pelvic floor muscles. So a lot of people who have the tightness in the pelvic floor muscles as well, they can have, or if you've had stitches postpartum, you can have a lot of trigger points in the area. So those would be the individuals that we possibly get a subjective history where they state that they have pain with intimacy and intercourse, just because of the pressure on the tight muscles, that they're not able to relax and they have a lot of pain. And then we have some connective tissue issues as well, where people have pain on the exterior area as well. And then we talked about the pelvic organ prolapse. That is basically where you've got your organs, and it can be your bladder, it can be your uterus, it can be your rectum, where the pressure, where they've actually kind of descended a little bit into the pelvic floor, and the pelvic floor typically cannot hold those organs up to the same extent as they're supposed to. So they get to start descending. So you feel this like pressure feeling in the vaginal area that you can't seem to get rid of. And with those individuals, there's a lot of factors that play a part in that. It can be, you know, emptying of your bladder, making sure that you're drinking enough water to flush everything out, making sure that you're not constipated, because when you're constipated, it puts pressure on that area, and that can affect a uterine prolapse or a bladder prolapse, or especially a rectal prolapse. And then pelvic floor weakness can play a major part, and as well just your coordination of your diaphragm and your pelvic floor, that if they're not kind of working together, you can have increased sensations of that pressure as well. And then we've got the diastasis recti, which a lot of people can have. Children have it as well. It's really common in children, but we can have it postpartum. You don't even have to have had babies to have the diastasis recti. If you guys don't remember what that is, it's basically where your rectus abdominis muscle, you know, where you've got well, we all wish we had the six pack. And you start to get a little bit of separation of the abdominal wall. Now, typically when we measure it at the level of the belly button, above the belly button, and below. What's normal is anywhere from like a half a centimeter to a centimeter. But a lot of individuals can lose that bracing, and they can have anywhere from, you know, I've heard of people having like 9 centimeter difference. And for individuals like that, it has a lot to do with breathing and the ability to kind of learn to brace those abdominals together. Because typically when we're pregnant, we start to have that belly expansion, and it's just automatically kind of separating the abdominal wall. And the white tissue between the six pack, or that rectus abdominal muscle, it's called the linea alba, and that can typically be stretched. So with physio, we're teaching patients to re-brace and to try and connect that tissue again. And a lot of the time it has to do with, like I said, breathing patterns, just that motor control between your brain and your abdominal wall, and trying to visualize that bracing technique. And then pelvic health also, like I said, people who have long-standing hip pain, low back pain, or SI joint issues, we kind of encompass that into pelvic health as well. So it is a huge umbrella, and that's just kind of the types of conditions that you see, that we see clinically. The past couple years, pelvic health has really kind of jumped on the radar, especially since roughly 2010. You've really seen a big jump in the amount of pelvic therapists. It's definitely one of those niches. Not everybody can do it, but I had some pelvic health issues after Aria as well as after Mila, 2 separate issues. So it's kind of been a major player in my life, and influenced me to a large degree. So I'm trying to give back to the community, because there's too many GPs and OBs that brush off pelvic health issues and just tell you that you're okay when sometimes you're not. So I want to be able to let individuals know that it's okay to talk about it. If you have pressure down there, if you leak, if you have pain with intimacy, it's okay to talk about it, and to reach out with somebody who's experienced it, or that can help you, is definitely the way to go. It's not something that you need to bottle up and live with, especially if we can hopefully improve how you're feeling about it, your symptoms, and your quality of life. So where do we go from here? Does anybody have any particular questions? I know this is a crazy topic, and not everybody likes to talk about it, and some people just like to listen and learn rather than ask questions, but feel free to ask away if you want to. I don't mind answering any specific questions if we have any. So where do we go from here? I'm just going to kind of teach you a couple of different things about why breathing is important with the pelvic floor with respect to incontinence, as well as pelvic organ prolapse, and all those other things. We talk about the piston effect. That's what I usually teach my patients first and foremost. If you don't understand the way that your piston works, then you won't understand the basics of the pelvic floor and how breathing and pressure, or intra-abdominal pressure, can affect the pelvic floor. So here's my good old chart, right guys? Except I'm on the left side and I'm not left-handed. So I have a question. Frequent UTIs be linked to a weaker pelvic floor? I wouldn't say always linked to a weak pelvic floor. It can, if you're not getting full evacuation of your bladder, sometimes we see that they have frequent UTIs. UTIs can be a variety of different reasons. But usually it's not just one issue. There's usually multiple. And it can be a wide variety. So I discussed that with you on your own, but making sure that that your bladder is fully evacuated, and make sure that you're not having any urine that's sitting in the bladder for any prolonged period of time. Now, one of the first things that I teach people about is their bladder, and one thing that's really cool, not really cool, but postpartum, the major thing that I hear people is moms always have to pee all the time. And what a lot of people don't realize is, if we think of your bladder, right? Your bladder has a capacity to hold, I'm not a lefty, remember, about 400 to 500 mils of urine. And sometimes we start to see individuals with the stress incontinence and people who have an urge incontinence. And when I tell them that it holds 450 mils, they look at me like, what does that have to do with anything? But a lot of the times we develop this habit of going to bathroom a lot, just before we leave the house, just before we go to bed, just before we go outside with the kids. And what ends up happening is, when we actually get this little tiny inkling, and it's kind of like a reflex, when our bladder fills about 100 mils, that's not the point that we're supposed to go to the bathroom. We're supposed to actually wait until it hits, like I said, that 400 to 500 mils. And what happens is, if we start to go around this 100 mil mark, you'll notice that when you sit on the bathroom, you'll actually only go pee for, if we talk about Mississippis, you're probably only going to go pee for like 4, 5, 6 Mississippis. The 400 to 500 mils, when you sit to go to the bathroom, you're going to notice that you're anywhere like roughly around 9 or 10 Mississippis, and this is when you're getting full evacuation of your bladder. Now, it's relevant because if you keep going at this 100 or 200 mil signal that you receive, what ends up happening is it becomes a habit, and you're always going to feel like you have to go at that point in time. And people say, well, is it bad for me? Well, yeah, because you're not actually getting that full fill up of the bladder, and the muscles of the bladder are getting trained improperly, if that makes sense. And then it leads to that urge feeling where you feel like you have to go all the time. I hear a lot of moms say, they went to the bathroom half an hour ago, but now they're taking the kids out, so they're going to go pee again. Or they just went, they went pee at 9 o'clock, and then they're going to bed at 10, they're going to pee again. You actually don't really have to pee at that point. You can probably go all night. That we're just developing a habit, which is not good. So the test that I ask you guys, as funny as it sounds, is the next time you go to pee, or the next couple days, just count how many Mississippis you pee, and see whether or not you're actually getting like a partial filling of the bladder, or if you're getting a full fill of the bladder. Okay, and usually that's relevant to your urge incontinence. And then, okay, so that's your bladder. And then we talk about the pelvic floor and the diaphragm and the piston. So people say, well, what the heck is the piston? The piston is just a visualization that we use with respect to the pelvic floor. So we talked about, so this is your sternum, these are your ribs, and then your diaphragm is kind of like a dome-shaped tissue that sits underneath your ribs. Remember, I'm not a lefty. And then your pelvic floor is that sling that's on the bottom. So the diaphragm is the top of the piston, and the pelvic floor is the bottom of the piston. You've got a posterior aspect, which is muscles, and then you've got an anterior as well. So your transverse abdominis and your multifidus. I won't go into detail about those two. So your pelvic floor, we talked about like weakness or tightness there. But when we breathe in, you're filling your air with lungs, right? Or filling your lungs with air. And when you breathe in and you fill your lungs with air, what ends up happening is the diaphragm pushes down. Except you have organs, obviously, everywhere in your stomach. So when the diaphragm pushes down into the organs, they have to go somewhere. right? And there's an increase in pressure. So everything has to go everywhere. So when you breathe in, your belly should expand. You should get this outward movement of your rib cage. But then there's also pressure down into your pelvic floor. And your pelvic floor is very pliable. So it should descend and relax and stretch as the diaphragm contracts and pushes down. That's the downward movement of the piston. But as soon as you exhale, what should naturally happen is the pelvic floor there should be this kind of connection in your brain that says, pelvic floor, okay, we need to contract and lift everything up because the diaphragm is now going to push back up and expel all of the air out of the lungs. But typically what happens is sometimes that doesn't occur. So when we breathe in, if people who are really tight can't relax their pelvic floor isn't going to descend like it's supposed to. Like it's supposed to kind of go down like this, but it doesn't. So that's somebody who's really tight. It's not going to get that descension. People who have the stress incontinence, where they're getting leakage, when they get that downward pressure of the diaphragm through the pelvic floor, their bladder, if it's full or partially full, is going to push down against the pelvic floor. And sometimes if they cough or they sneeze, that sort of thing, they can't get that full closure of the muscles, the pubovaginalis, the pubococcygeus muscles that surround that area. If they're not going to get full closure, they're going to get some leakage through the urethra out of the bladder, and then they're going to leak. So the coordination of breathing, pushing down, the diaphragm pushing down through the pelvic floor, and then as they exhale, contraction of the pelvic floor coming up as the diaphragm elevates, that's the piston effect. And if that it's not just strength of your pelvic floor, it's the coordination of the two, which is really important in people who have pelvic concerns. So that's kind of the bladder, that's the piston effect. And then, like I said, variety of other different issues. Constipation is a huge issue that we talk to patients about. Just making sure that they're getting enough fiber intake, water, H2O intake, daily physical activity, that sort of thing. So that's kind of a basis of what the pelvic floor is. But then we talk about what does physio do. So as physios, when a patient comes in with a pelvic concern, what we first and foremost do is get basically a subjective history. What sort of symptoms are they having? When did it start? Was there an actual trauma, a mechanism, that sort of thing? What symptoms are they having? And we try to dive into it. Like if they had kids, we try to find out how their birth was. How long were you pushing? Did you have an epidural? How were you post birth? Did you have stitches? Did you have an episiotomy? There's so many different factors that can contribute that we have to really gather a lot of information to be able to determine kind of what route to go with the patients. Do they have a previous history of pelvic issues? Did they had one child, 2, 3, 4? Did they have any pelvic health issues, when they were younger? Is this new? Is this old? Is it worse? So that's kind of the basis to where we get our information. And then we do what we'll call like an objective assessment. And that's where we're taking a look at not just their pelvic issues, but their low back, their hips, their pelvis, their knees, like a variety of different factors. And then if it's appropriate and if we deem that the patient's comfortable, then we do the external and the internal exam. Our goal is, I as an example, sometimes I have patients with a pelvic organ prolapse, and we grade prolapses on degrees of dissension of the organs. And the patient, actually I had 2 or 3 patients in the past little while say, is this going to go away? And my answer was, my goal is to reduce and address your symptoms. Is your prolapse going to go away? I can't tell you that. And prolapses don't usually go away, but it doesn't mean you have to have symptoms either. So with pelvic health, our goal is to address everybody's symptoms, to get to the cause of their symptoms, and make sure that we address all of the variety of contributing factors. You can tell that I'm a big individual who focuses on contributing factors, on that sort of thing. So, as an example, a few months ago, I had an individual who she was a runner, and she had 2 children, and she had a complaint of urge incontinence and stress. So she always felt like she had to go to the bathroom. She also leaked anytime she coughed, sneezed, jumped, and ran. She had no issues prior to her second child. Birth was pretty straightforward. She did have an epidural. I think 1 or 2 stitches, nothing major. So we did the assessment, and we just found she had some weakness in the pelvic floor, so she was unable to get a really good contraction. And when we look at the strength, we look at 2 different things. We look at basically the fast twitch fibers, so the ability of an individual to contract really fast, that pelvic floor. That's what you need when you cough and when you sneeze. And then because she's a runner and it's more of a longer distance, she also needs what we call slow twitch fibers. So the pelvic floor muscles that need to contract and hold for longer periods of time. So she had a discrepancy and a weakness in both. So that was one of her primary issues. And, was it because, 2 babies, and the first baby, she didn't have pelvic physio. So she may have just developed a weakness over time. And her breathing was an issue. So she was more of the chest breather. So she wasn't getting that coordination between the diaphragm and the pelvic floor. And then we looked at urge incontinence, and she had developed a habit with anytime she went out, she always went to the washroom. So we worked on a couple of strategies to try and reduce that. If she was going out and she hadn't gone to the bathroom in a while, she went. But if she had gone within 2 hours, to distract herself, she just counted back from 10. And then it got her past that urge, and she went out and about and didn't have any issues over time. And then we worked on her fast twitch fibers to try and get those muscles to contract quickly for coughing and sneezing. And that worked really effectively. And then we worked on her motor control and her coordination and breathing for the slow twitch fibers, so that eventually when we kind of progressed her breathing in Kegels from, supine, side lying into more functional movements, sit to stand, bridging, one leg balance. Eventually she was able to run with less symptoms, because she was able to initiate those muscles, and it was more of a habit now. She didn't need to actually tell them to turn on. They were functioning when they needed to. So pelvic health is, like I said, a really cool area that a lot of people don't know about. So if you guys do know anybody that suffers from pelvic health issues, and they're nervous to talk about it, they don't want to talk about it, I'd encourage them to reach out to somebody like myself, even just to kind of get some insight to what's going on and whether or not we can help them. I don't want people to suffer in silence, because they don't need to, and they're not alone. And especially on Mother's Day, this is the time to talk about it. So feel free to reach out to me, you guys, if you have any issues or you have any questions or concerns, and I will help you and answer what questions I can. And if I can't answer them, I will find the answers for you. If you guys know anybody who would benefit from watching this, with respect to the educational component, or kind of the different types of conditions, if you think that maybe they might be having these issues, feel free to tag them in the video, or you can share it with them as well. Our videos and such are all on our Facebook page, as well as we do have a YouTube channel now as well, so that the general public can access them. And I think that's about it for tonight. If any of you guys do have any specific, things that you want me to do a workshop on, or if you want me to dive deeper into certain conditions, not just with respect to pelvic health, but respect to anything, feel free to reach out to me, because these workshops are for your benefit, and I just would like to educate you guys as much as possible, and let you know if, can you help yourself on your own? Can I help you? That sort of thing. Or if you have any other ideas that you'd like me to see me do live, I am open to that as well. I just want to serve you while we are, well, not just now that we're at home, but from here on out, I want to be able to kind of guide you guys and inform you as much as I can. So this week, I'll be posting our next set of workshops, so stay tuned. And if you don't mind, I'd really appreciate it if you could share this workshop later, so that we can extend it out to the community as much as possible. So happy Mother's Day again. I wish you moms and all those individuals in the roles as moms all the best. We love you, and we see you, we hear you, and we support you. So good night, everybody. Good luck tomorrow on your next day at work. And for those of you provinces that are opening up, good luck. Be safe, and we are thinking of you. Take care.